Quit sticking your tongue out. Does this guy look like he's in trouble? So what do you think is wrong with Bob? We're guessing Bob is having an allergic reaction at this time. Anaphylactic reactions are divided into food, stings, latex, and medication. Pollens are less likely to cause anaphylactic reactions. An allergic reaction is a hypersensitivity of the immune system to something in the environment that usually causes no problem to normal people. Allergens can be food, like seafood, being the most common, and peanuts are considered one of the most severe common allergies. Stings and venom, and then food medication. Just because you're not allergic to something today does not mean that you won't become allergic to it later in life. So what really caused Bob's problem? Either an IgE or a non-IgE mediated response. So an IgE is a body's exposed to an allergen and produces the IgE. The production of IgE causes the body to become sensitized to the allergen. Now, in subsequent exposure, mast or basophils become coated with IgE, which causes the release of histamines and other mediators. These are typically normal allergies, foods, or stings. There's also non-IgE, which is basically the same result as the IgE, but with no previous exposure. They're treated the same way. Some of the common causes of those are non-steroidal anti-inflammatories, narcotics, muscle relaxants, X-ray dyes, preservatives, sulfites, and physical exercise. The reason that those are contributing factors is not exactly known, but all I know now is that I can't exercise because I may be allergic. Part of that with the exercise-induced allergic reactions have been linked to normally non-allergy-inducing foods that are ate right before vigorous exercise. And some of the foods that's been linked to that specifically are celery, nuts, shellfish, and wheat. However it is, I'm not going to take a chance. So just because you have an allergy. Allergic reactions can cause a variety of symptoms. Early symptoms usually appear as changes in the skin, like a rash, blotchy skin, itching. And even at this phase, you can start having that feeling of impending doom. I'm dying. Somebody's got to help. As it continues, swelling of the face, swelling of the airway, hypotension due to vasodilation, difficulty breathing and swallowing, and gastric symptoms. Those gastric symptoms can include nausea, vomiting, diarrhea, all the fun stuff. So Bob looks bad. What do we do for Bob? Of course, IV, oxygen, cardiac monitoring is always indicated. And then there's several things that you can do beyond that. Normal saline, wide open, your Benadryl, your Decadron. If they're wheezing and short of breath, your albuterol will also help. So with Bob, we've given him all those things, and none of those are helping. His tongue keeps getting bigger. How do we get that tongue back in his mouth? If you've gone that far and it's not working, epinephrine, 1 to 1,000, 0.3 IM. The insulin syringe is perfect for drawing it up, but the needle is not nearly long enough. The recommendation for an IM injection is a needle that's at least 1 to 3 inches long, depending on the size of the patient. If you have a obese person, that 3 inches may not be big enough. And it should be a 18 to 24 gauge needle. The needle on the 3 cc syringe that we carry here at Newton County is an 18 gauge needle. In with the good air and out with the bad air. If Bob isn't breathing, can he be intubated? That's a good question. If Bob's not breathing, his airway may already be completely closed off, and you're probably not going to get a tube past that. I'm not saying not to try, but you also have limited time with Bob because he's not breathing. So if you're not going to be able to intubate, then you're going to have to think about your next possibility, which is going to be needle cricothyrotomy. It's not the hardest nor the easiest of procedures. You're going to identify that cricoid cartilage, the thyroid cartilage, and the cricoid membrane. You're going to want to clean that up because you're basically doing a surgical procedure at this point, even though we're not doing a cut down. But go ahead and use that betadine. Now, if you're going to have to run 6 blocks back to the truck, you're going to have to make that decision on your own. Is that working? So you're going to attach a 14 gauge needle to a 5 cc syringe, and you're going to stabilize the insertion site with your non-dominant hand. So you're going to hold everything in place so that you're not dealing with the skin rolling over the top of the anatomy or the anatomy moving a little bit. You want to hold everything as still as possible. You're going to insert that needle at a 45-degree angle towards the feet while aspirating. So you're going to do that all at one time. You're going to be pushing it in and pulling back at the same time. Aspiration of air with little effort indicates that you've got a proper placement. So now that we have that in there, how are we going to get oxygen to the patient? You're going to have to take that tube connector off of a 3 cc syringe, and then you can connect that to your oxylator or your BVM. Your oxylator is going to be able to provide a more forceful ventilation than what your BVM is going to do, and it's also a lot easier because it's a matter of pressing one button whenever you have it set on demand, and instead of trying to squeeze that bag and then dealing with stabilizing your needle and everything else that you've got going on. The one time that I've done it, it was a 2-man operation. So we're breathing for Bob a little bit. His tongue is starting to go down. It still doesn't look good though. At this point, we're going to have to be thinking shock, and I'm not talking about with your defib pads. We're talking about maybe Bob is in shock. Don't go electrocute Bob. If his BP is less than 90, it's time to start getting some fluids on board. You're going to want to go ahead and infuse a liter of normal saline. And if that BP continues to decrease, here at Newton County we have Levofed. Your dose for Levofed is 2 to 4 micrograms a minute, and you're going to titrate that dose to to a systolic blood pressure of 100. To get that with the supplies that we have, you're going to mix 2 ml, which is 2 milligrams, into a 250 ml bag, and then once you're using that concentration, it's going to be a little bit easier to remember what your drip rate needs to be. So when you're using that 60 drop set, you know that 2 is going to match up with 15 on the clock. So 2 micrograms a minute is going to be the same as 15 micrograms, or 15 drops a minute. And if you're looking at the clock, you jump up to 4. That's going to be the 30 position on the clock. That's going to be 30 drops a minute. 6 is going to be at your 45. Just a way to remember it. So 6 drops, it's going to be at 45 on the clock. And then 8 drops, it's going to be at the 60 position on the clock. Just a way to think about that and try to remember, so you're not sitting there having to do any math or anything like that. 2, 4, 6, 8 follows the clock at 15, 30, 45, and 60. If that BP stabilizes, just go ahead and continue with your infusion of normal saline and an appropriate rate to maintain that blood pressure. So, Bob, let's not do this again. If you're allergic to peanuts, stop eating a Snickers bar. Education is a part of EMS. It should be always. We got to educate people on reading labels. EpiPen doesn't do you any good if you're inside the house while you're outside swatting bees in Florida. And there's also treatments that patients can seek out. Allergy immunotherapy involves giving just a small dose of an allergen on the skin for an extended period of time. It's been proven to work for all levels of reaction, from just minor clear up to full-on anaphylaxis. They do that really slowly, though, and it's a monitored process, and they'll give those over a period of 1 to 5 years. And most people can achieve an acceptable level of tolerance where, every time they sniff a peanut, they're not going into full-blown anaphylaxis. But it's important to remind people to read those labels carefully and avoid those known allergens. So a case study, 6:30 in the morning, call to an unknown problem man down. This out in a very rural area, pulled up into the driveway after we found it, and there's 5-foot tall grass that you got to drive through to be able to find a mobile home. You hear some people shouting with our windows rolled down, and on the porch we find a 36-year-old female on a small wooden porch. Family members can't even get the door open. They're just cracking the door and hollering for help. Physical exam. This patient has a tongue that is swollen almost outside their mouth, and they are just barely breathing around that tongue. The entire face is swollen, along with the head, neck, and it's starting to move down into their chest. All that area is starting to turn red and swell. So intubation around the tongue was not possible. One of us started working on a needle crike, and once we got that pushed in there, there was nothing but thick bloody mucus that started clogging the catheter, and both blood and mucus, I guess I could say. Took off to get the Epi 1000 and administered it. That allowed us to go ahead and intubate that patient very quickly afterwards. At that time, we were still using Benadryl and Solumetrol were administered after IV access was gained. And while we were doing all that, first responders showed up, and we were setting up a landing site, and the patient was flown to the hospital. After checking up with them, that patient never did completely regain full consciousness. And the final outcome was the patient extubated themselves at another hospital, and they were still having an ongoing reaction. So even several days later, they were still, every time that they would try to slow down their treatment, they kept swelling back up, and the patient ended up dying after they extubated themselves. The cause of that reaction was a severe allergy to wasp stings, and they found a wasp nest over the door. Case study 2, called Camp Crowder for breathing problems. We had a 24-year-old male with a history of asthma. Says that he was outside doing some physical tasks and became short of breath. He appeared to be a moderate shortness of breath. Had no recalled history the first time that we talked to him of allergies at all. He was breathing 22 times a minute, had an O2 sat in the upper 80s to lower 90s, and a pulse rate of 110 to 120. Wheezing bilaterally. No other symptoms were reported. He was anxious. Only history was asthma since he was a child, and he did not have his inhaler. No reported allergies at time of interview, and no men's reset. So what happened? We put him on O2, IV, cardiac monitor, albuterol, solumenderol. No improvement. He kept getting more and more short of breath. So still going along that asthma pathway, continued to mag sulfate, and he just, with everything that we did, he kept getting more and more short of breath. On the way to the hospital, he started reporting to having some trouble swallowing, and then started having some redness and swelling in his face that was not present where we initially picked him up. So at that point, we stopped mag sulfate and gave Epi 1000, and he had a quick and profound turnaround. After arriving at the emergency department, the patient remembered taking a pain reliever earlier in the day. He also remembered having a reaction to aspirin as a child. He was not aware that the combined migraine medication also contained aspirin, and not that he would have changed his actions anyway, because he only had the reaction to the aspirin one time as a child and didn't realize that he was allergic to it. And that's allergic reactions.